All the evidence shows that walking and swimming is not adequate even for maintaining bone. No, that's all you're doing. You're going to keep losing bone. It's better to do them than to do nothing. My mantra is definitely the best exercise for any person is the one that they will actually do.
Here's something to think about. Can lifting heavy weights really be as powerful as medicine in treating osteoporosis? Our guest today, Professor Belinda Beck, has spent her career proving that it can. Welcome to Brighter 100, the podcast where we explore the science and stories shaping the future of health and well-being. I'm your host, Anil Casey, and today we'll dive into her groundbreaking work and what it means for bone health, aging, and longevity. Professor Beck is the principal investigator behind the landmark LIFTMOR trials, which showed that the right kind of resistance exercise can actually reverse bone loss and protect against fractures. She has published more than 100 scientific papers, contributed to international guidelines on osteoporosis and exercise. A scientist and a pioneer, she is translating cutting-edge research into practical solutions that help people stay stronger for longer. Professor Belinda Beck, welcome to the show.
Delighted to be here.
Now, your work has positioned you as a global leader in exercise and bone health. But for listeners who may not know you yet, could you paint a picture for us? Who is Dr. Belinda Beck? The story of what first got you fascinated by the skeleton and why it really matters.
Okay, well, I'll give you the abbreviated version, but I'm somebody who has always loved physical activity, playing sport. I was a runner and a hockey player, and I always suffered from shin pain when I was running. And so what started me down the path of being interested in bone was an initial sort of interest in bone stress injuries and particularly tibial stress injuries. So that's what I did my master's project on. And then when I discovered how incredible bone tissue itself is, I was completely hooked. And that's when I sort of went down the path then of trying to investigate what it is about loading that bone can detect so that it adapts to it. Because, I think it's fascinating that if you go into space, you lose bone. And if you overload bone, you grow bone. So my PhD work was an animal study. And then I decided I didn't want to work with animals I didn't want to kill animals for the rest of my career. So then I began working in clinical trials, and I did a postdoc at Stanford University. Then I came home to Australia, and I've been teaching musculoskeletal anatomy and doing research on bone and the effect of exercise and other forms of mechanical loading on bone ever since.
So was there any moment when you realized that bone health wasn't just a scientific topic, but something that could change everyday lives?
Well, that's an excellent question. I've had a few moments like that, but probably the first time somebody ever said to me, "This exercise program you've given me changed my life." And it's got nothing to do with my bones. It's just that I am so much more physically capable now, and I've regained function that I thought I'd lost forever. My quality of life is better, which has made my mental health better. I'm much more social and confident. So what I do for the purposes of improving bone health is so much more for the recipients of that, because for them, it's really just about quality of life.
Is there a big difference between what you studied and what you're applying at your clinic?
So there's a large difference in terms of what I studied as a student, because at the clinic we've got humans, and my master's I worked with cadavers, dead bodies, and with animals in my PhD. But there's not a heck of a lot of difference between what we studied in our LIFTMOR clinical trials and what we apply at clinic, because we discovered the recipe, what works to improve bone in people with low bone mass. And so if it's not broke, why would you fix it? So we do exactly that, and we just add a few little things here and there to make it better and make it more meaningful and useful for people. But no, we rolled out the actual work that we discovered was effective in research.
Yes, I'm definitely going to be talking about your LIFTMOR study. But before that, if there was one myth that you could bust about bones, muscles, and aging right at the start, what would it be?
Oh, that myth is once you have osteoporosis or as you're aging, you're stuck with osteoporosis for the rest of your life and your bones are just going to get worse forever. That is a myth, and we bust that on the daily.
How do bones and muscles really work? How would you define bone health?
Well, I suppose from the layperson's perspective, bone health is just a bone that functions in the best way that it is supposed to function. That is, it holds us up when we're standing. It protects organs like our brain and our lungs and so on. It provides a reservoir for calcium and other minerals, and it is strong enough to resist insults such
Right.
as would happen if you had a fall or some other form of trauma. So a healthy bone is a strong bone that's not likely to fracture, but it's also a bone that has availability of this reservoir of minerals that we use.
But most people, they think of bone health as a fixed and unchanging. How would you explain what's really happening inside our bones on a day-to-day basis?
Yeah, that is interesting because particularly if you eat meat and you see bones inside meat, like a chicken bone or something, it looks like a very inert, just like a piece of plastic or a piece of wood. It is so much more than that.
Right.
Those inert things can't change once they have a certain shape. But bone is live tissue that's full of cells. It's got a wonderful blood supply. It's got
Right.
nerve tissue and lymphatics. It's got all the things in there that are necessary to make it a live and adapting tissue and reacting to stresses. So that's the difference. It's an incredible changeable structure that responds to both chemical and mechanical environments. The only difference there's many differences between bone and muscle, but in terms of its ability to adapt, the main difference is that something like muscle will adapt quickly because it's a very labile, sort of soft tissue, whereas bone, it takes much longer for it to adapt because it's hard, and cells are little tiny things. To resorb some bone, it takes quite a long time, and to build bone also takes a long time.
That's interesting. So, do muscles and bones really talk to each other? And, why does it matter? The communication for staying active and independent, does it really matter?
Yeah, why do bones and muscles talk? There is actually a thriving area of research with myokines and that sort of molecular biology. I'm not a molecular biologist, so I'll leave that to them. But probably from my standpoint, why muscle is so incredibly important to bone is because it applies load to bone. So not only a muscle, for example, bicep is attached to the bones in our forearm, and by virtue of that attachment, pulling on that
Mhm.
bone, it can create movement. But that
Right.
pulling on that bone is a mechanical force, and the bone is responsive to that. If you take that mechanical force away, the bone will actually get less, reduce its mass. So the force of muscles is very, very important to the strength of the bone.
And what are some of the biggest everyday habits that hurt bone health without people realizing about it?
So I'm a little biased in my answer, but I think the number one reason why bone health deteriorates over life is because we become progressively more sedentary. So inactivity is the worst thing for bone. It's like going up into space where there's no gravity on the skeleton. The skeleton sees inactivity as it not needing to be as strong as possible. So it will get rid of extra mass. And all that means is that your skeleton then is going to be more susceptible to fracture. So physical activity, loading is absolutely vital, but of
Mhm.
course you do need the building blocks. So your diet is also important. So if your bone does need to adapt, then it does need to have calcium available to use as building blocks and a bunch of other nutrients. It's the most important one, calcium, but there's plenty of other little ones, micronutrients that help.
Right.
I don't like to focus too much on nutrition, one, because it's not my specialty, but two, because there's to my knowledge, there's never been a nutritional intervention that can bring somebody from osteoporotic back to normal bone, whereas there have been exercise
With exercise.
interventions where
Yeah.
osteoporotic bone can. So mechanical loading is a much more powerful stimulus than nutritional. It's really important to make sure that the building blocks are available.
And, how much of bone decline would you attribute to biology and how much is actually the long tail of reduced movement, like you said, inactivity?
So I would say nobody knows the answer to that, actually, but the quick answer is that between 60 and 80% of the amount of bone that we develop, now our bone health and mass and architecture is determined by our genes. It's what we inherit from our
Right.
parents. So the amount that we affect that is just a reasonably small percentage. Genes determine your bone health to a very large extent. But I would argue that across your life, after you've gained your peak bone mass, round about the end of the second or third decade in there, that loss across life
Hmm.
is sedentarianism. It's because people don't maintain the levels of activity as they did when they were young. And if
Right.
you do maintain it, you can maintain your bone mass. So it's people would say you lose bone, everyone's going to lose bone with age. Well, maybe there are functions that get worse as you age, and your cells are not as responsive to various things. But if you look at the bones of masters athletes who remain as active as they ever were when they were young, you'll see that they plateau. They don't lose the same amount of bone mass as sedentary people. So that's the important
So,
element.
so what you're saying is, yes, there's going to be decline in terms of the bone mass, but with exercise and with movement, the decline is much more gradual as we age, post 20 and 30 years of age.
That is what I'm saying. And some lucky people don't lose any bone at all. I mean, it's just, again, that rate of loss is almost certainly a genetic thing.
Right.
And there are different types of loss to the mass overall and loss to the interconnectivity of the trabecular bone, which really does have a huge effect on the strength of the bone. So some people tend to have perforations in those trabecular structures, which make their bone much more susceptible to fracture than someone who maybe has the same bone mass but has more interconnection. So the whole thing is quite complex, and it is related very strongly to genes with an overlay of influence of your mechanical loading or your physical activity levels.
What is the one thing that you wish clinicians and coaches would bear in mind when they're training older adults? And what are some of the misconceptions that are there amongst most practicing clinicians when it comes to bone health and especially with exercise?
Oh, well, probably the primary one is that old people are frail and fragile and can't do anything. And
Right.
that's and the fact is old people are just you and I who are older. And there's nothing that's going to stop us doing the things we want to do if we keep doing them now while we're young and maintain our strength. So this is a real myth that old people can't do anything. And particularly, even when somebody is very old and they are quite frail, they're the ones who have the most to gain by doing at least something. And the wonderful thing about how the body adapts, if you do something and your body adapts to that, then you can do a little more. And it is a progressive improvement. So we talk about the initial values principle. That means the people who are the worst
Mhm.
respond the most. And that's definitely the case when it comes to muscle and bone.
So now we come to the menopause, right? The menopause bone cliff. Why is menopause such a big moment for women's bone and muscle health?
It turns out that estrogen is sort of the queen of bone. It's a it's a hormone that is extremely important to preserving our bone because we have certain bone cells called osteoclasts, and they're the ones that are responsible for resorbing bone, sort of absorbing some of it up. And this is really important either for fixing micro damage that you can get in your bone or for releasing some of those minerals I mentioned into the blood so we can use them elsewhere, because bone is this reservoir. So those osteoclasts, those bone resorbing cells, are inhibited by estrogen. So estrogen sort of stopped them working as much. So in menopause, when circulating estrogen really decreases and it's withdrawn, then the osteoclasts just have a little party for a while And
Right.
it's now's the time to attack bone, and they resorb a lot of bone for over a period of about 5 to 8 years, and then it sort of goes back to a normal pattern of remodeling.
Okay. So, would you say that estrogen is the key hormone when it comes to bone health for menopause?
100%.
Okay.
Yes, it is.
And let's talk a little bit about hormone replacement therapy. What role do you think hormone replacement therapy can play in protecting bone and muscle? And how would you explain the timing window? Like, who would best benefit and whether it's just estrogen alone or is it a cocktail of hormones? How would you explain that?
These days, instead of hormone replacement therapy, they tend to call it menopausal
Right.
hormone therapy, supplementing or replacement of estrogen and various other things uh, at the time of menopause, in menopause, is the time to protect bone from that loss that is associated with the withdrawal of estrogen. So that is a window. And that window tends to close about age 60
Mhm.
because there's an idea that it's not, after the age of 60, it's not very safe to then give hormones back to women because they probably will have been hormone free for about 6 to 8 years already. And so all of the negative side effects that were seen in a study about 20 years ago were seen in people who were older. So the idea is that you probably need hormone therapy around about the age of menopause and in the following years. But if you miss that window, then perhaps there are other strategies that you should take. Now, I'm not an advocate one way or another. I think
Right.
that I leave those to my endocrine peers.
But in your experience, do you see any synergy between HRT and high intensity training and the benefits that women get?
The jury is still out on that too, actually, because there's not enough data. So the
Mhm.
study has never been done looking specifically at menopausal hormone therapy and our kind of high intensity training. What we have looked at is other kinds of bone medicines. So there is a little bit of a relationship there, but not specific to hormone therapy.
Mhm.
My suspicion is that there would be, because if you are clamping down on osteoclasts, the bone resorbing cells, but the exercise is encouraging the osteoblasts, which are the bone building cells, then the combination should be good. But the body has a way of outsmarting us for whatever reason. And sometimes what's intuitive doesn't happen. So we really do need to do the study to know the answer to that question.
Right. So, what would you say are the most effective ways to protect bone and muscle in during menopause? And of course, keeping HRT aside for women who do not want to take HRT, what would you say is the best solution?
Oh, well, best solution in during menopause is exactly the same solution at any time of life. It's
Movement.
main just maintaining this exercise sort of overload. So loading the bones and muscles when you're young and your bones and muscles are quite strong and the rest of you is quite strong, then you can be very aggressive in that. Many things that you can do, lots of jumping, all kinds of different activities. And you can do that throughout adulthood, including at menopause. But when you have, and if you have, as a sort of an osteoporotic diagnosis, then you have to just be a little bit more careful as to how you do that. And almost certainly you're going to need some supervision.
Are there any myths around women lifting weights? We hear a lot about that in India about women should not be lifting weights and they should not be building muscle and so on. And even among women, there's a lot of that misconception saying that, oh, if I'm going to lift weights, I'm going to start looking like a man. What are some of the myths that you've seen and what would you wish disappear forever as far as exercise and medicine is?
Well, I mean, in this day and age, I think because muscle really is, I said estrogen was queen, muscle is king. I mean,
Right.
muscle is the most important tissue for maintaining health of so many systems in the body. So when people say to me, oh my goodness, I'm going to turn into Arnold Schwarzenegger, I can only say you wish, because it's not going to happen. There's no chance in the world that it's going to happen. We've had 10 years of people lifting weights at the bone clinic, and I have yet to see anyone who even looks enormously muscly, even though they're lifting heavy weights. Women, it just won't happen. What will happen is you'll get beautiful, strong limbs. You may get some nice shapely limbs. Your arms and legs will start to look.
So-called toned body, as they say. Is that?
That's right. So your posture will be good. Your clothes will fit you nicely. So it will be an aesthetic appearance. If anything, you'll be slimmer, but you certainly won't have big bulky muscles. That just does not happen. In postmenopausally, I've never seen it.
Right on. So the LIFTMOR study, a highly respected study at a global level. Tell our audience a little bit about your study and the findings.
So this is back in about 2013 when people like me were getting slightly frustrated that we were testing all sorts of different exercise programs and nothing seemed to be growing bone, and until we realized that we really did need to load it more heavily because that's just how bone reacts. So somebody had to bite the bullet and just do it. And that somebody was us. So we decided to do a high intensity resistance and impact training. We call it HIRIT for short, exercise program. These were, and we don't talk about exactly what the exercises are because it's not safe for people to just listen to Belinda talking on a podcast and then go and do it themselves. They must be supervised. But these are big compound movements that it doesn't take very much of them, but you have to be lifting heavy. And there's an impact exercise as well because the impact is also important. But we did that twice a week, 30 minutes for 8 months. And lo and behold, we grew bone and muscle, improved function and risk factors for falling. So this was really a step change in terms of exercise recommendations for people with low bone mass, because some of the women in this study had extremely low bone mass and some of them had prevalent fractures. So they already had a what they call the dowager's hump or the kyphotic curvature in the top of their spine. So these were very high risk people, and they managed to do the program. They grew bone, and best of all, over the course of 2,600 exercise sessions, only one person had one mild muscle strain in the whole study. So, it was pretty impressive.
Yeah, it is. So you mentioned kyphotic syndrome. Were they able to reverse any of it, or did they kind of stall the progression? So were there any of those findings?
Yeah, one of the really lovely things about the LIFTMOR study was how we showed in our HIRIT group, the heavy lifting group, they actually got taller because they were standing up more straight. So the exercises strengthened the back muscles so much that they actually improved their posture compared to the control group, which of course just got more stooped. So of course they're not growing. Their average age was 65. So they were this height improvement was purely postural. And of all the things that the women loved about this study, that was right up there with their favorite outcome.
So was it the spine which kind of corrected itself, or?
One of the reasons why kyphosis occurs, or this curvature at the top of the spine, the main reason in osteoporosis is when the little blocks of bone that can form your whole spinal column, the vertebrae, when they fracture with osteoporosis, they tend to fracture at the front. And so you can imagine that creates a wedge-shaped bone. And if you put a bunch of wedges together, it causes this curvature. So our program is not going to be able to rebuild that. It doesn't change the shape of a wedge-shaped fracture. That fracture is there unless you have it surgically repaired, which is, not necessarily advised, although it can be done. What the exercise can do is just improve the back muscle strength so that the person's posture is more upright, so that the likelihood of having another crush fracture in the anterior part of the vertebrae around it doesn't happen, so it doesn't progress. So that standing up straight helps to prevent other fractures from happening.
So was there any aha moment which you had while you did this study? which people still miss even today?
Well, I suppose my aha moment, and I will never forget it, was because when we started the study, I've been a researcher for many years. And when you try a new thing, particularly one that everybody has been saying is wrong or dangerous, you don't have high hopes for it. You don't expect it to work. You're just
Right.
testing it to rule it out. And the very first person who went through the intervention and was tested after their 8 months of high risk was tested on a weekend. And I was sitting with my family at home and my phone rang, and it was my PhD student who said they had just tested her and she had gained 9% of bone mass at the spine. That
Wow.
was my aha moment, that it
Wow.
actually worked.
Heavy, high velocity, or both? How do you think about squats or deadlifts, overhead work? What's the impact by age and in terms of hip risk or spine risk? What are your thoughts on that?
So heavy or high velocity, I would definitely say heavy every day of the week, as in that would be my choice every day of the week. I don't mean you do it every day of the week. High velocity is an approach that could be effective for bone, but I don't believe it's safe for people with osteoporosis. And I liken it, or I try to illustrate why I say that by giving people an image of, say, just a stick. And bending that stick gently will make it bend quite well without breaking. But if you bend it quickly, you probably will break it. And I feel like loading somebody to the degree that you need to load them to change bone mass and loading them that amount and quickly, it just puts the bone at an unnecessary risk. We've shown that you don't have to load quickly to get improvement. So my preference is people don't load quickly when they have osteoporosis, just in the interests of safety.
Right. But what about people who probably are 60, 65, but they don't have osteoporosis?
Well, I mean, they're welcome to do whatever they want, right? It's a free world.
Right. No, from a risk perspective, what are your thoughts?
So from a perspective of their bones, they may be able to tolerate it and it may be okay. From a standpoint of whether it is going to be safe in every circumstance for the discs in their spine, sudden movements are normally the ones that are associated with discs prolapsing and so on. Of course, we have to think about the fact that 60, 65, there are all sorts of comorbidities or other things wrong. So there may be people with dodgy knees or pelvic floor problems. Sort of a consistent application of force is probably safest for both of those things. I tend to say that the high velocity stuff, if it was me, I would be sort of containing that to the younger, healthy athlete sort of years. And I just don't see there's any need for it, because if you do, say, blow a disc in your back, then what are you going to do? Then you've got that for the rest of your life. And what for what?
Right.
Because you can just as easily do this kind of training effectively, slowly,
Right.
or at a
But I
regular
think
speed. I don't mean to go like a snail.
But I think that's where most people tend to start just walking or swimming. But do you believe that that's good enough to keep bones strong, or do we need to do something extra?
All the evidence shows that walking and swimming is not adequate even for maintaining bone. No, that's all you're doing. You're going to keep losing bone. It's better to do them than to do nothing.
Right.
And my mantra is definitely the best exercise for any person is the one that they will actually do. So if walking is the only thing that you'll do, even though it's not going to grow bone, you should still do it. It's better than not walking. But don't assume that you're doing anything for your bones by walking or swimming, because neither of those things will grow bone.
How quickly people feel or see changes once they start any sort of exercise from a bone health perspective?
So seeing a change in bone, if you went from doing nothing to doing a lot, you could probably see change within 6 months. But we don't tend to test people before a year. I mean, in the LIFTMOR, in our clinical trials, oftentimes we will only do an 8-month intervention, and that's because they're run by PhD students who need to graduate. So we don't have time for them to do a full 12 months. And 8 months is enough to detect a change, but 12 months is better, because when bone adapts, these tiny little bone cells extrude new bone tissue, but it's
Mhm.
organic, and the bone density machines don't pick that up. They can't see that. It has to be mineralized before that mineral can actually be detected by the machines. And that mineralization process is quite slow. So we do recommend that people wait a year before they have a bone scan. But the good news is that you will start to see changes in your muscle, in the function, and maybe even the appearance of the muscle after about 6 weeks. So those muscle changes are much, much faster, and particularly the changes in function, they happen reasonably quickly.
How does bone health tie into how long and how well we live?
Well, answer the second part of the question first in terms of how well we live. There's quite a lot of data out these days which is looking at quality of life after a fracture. Now, most of us think about quality of life after a hip fracture, and that can be a really sentinel event. This is something that many people end up in a nursing home because they can no longer live independently after a hip fracture. So you can imagine the difference in quality of life, being able to live independently and then being in a nursing home.
Right. And it's also called the beginning of the end, right? For older
It's the
adults.
beginning of the end.
Yeah.
So and the older you are when you have a hip fracture, the shorter the time period between that fracture and the time that you're dead. If you're 90 and you have a hip fracture, it would be extremely unlikely that you'll be alive in 6 months. So it is absolutely, a mortal wound the older you are. The younger you are, you can recover, but you almost certainly will never recover the same degree of function and movement. Now, a vertebral fracture is probably it's not likely to be something that will cause you to die. It will the fracture itself will heal, but if you've had a crush fracture or a wedge fracture, you will always have that reduction in height, possibly the kyphotic curvature, and possibly if it's encroaching on the nerves coming out of your spine, then there's ongoing chronic pain. And
Right.
the pain itself is bad enough, but the inconvenience of losing some height should not be underestimated. If you think about all the things in your kitchen that you can't reach, if you just lose just a few centimeters. So what happens when people do lose height is they start putting step stools around the house, which of course is a trip hazard. So really what's happening is
Wow.
setting yourself up for a fall, which is when the hip fracture happens. If you fall, say you're mid-50s and you fall on an outstretched hand and you break your wrist, your doctor should immediately send you for a bone density scan, because that's one of the number one ways that people discover that they have osteoporosis, because most people when they fall don't break a wrist. So that's that's what they call a sentinel fracture. It's identified the problem, and then you can do something about it to try and prevent those other things from happening.
Okay. Can you explain muscle strength, bone density, and balance? How do they work together to prevent the downward spiral, like you were mentioning?
Yeah, so training of muscle also trains the nerves that attach to those muscles. And that complex training with the brain and the muscles helps to keep us on our feet. Balance is something that we do tend to lose as we get older. And it takes a lot of training to be able to improve our balance and actually reduce our risk of falling. Uh, the Neuro program will reduce your risk of falling just by virtue of making your muscles in your lower extremity stronger,
Right.
and also it will train the nerves as well. But you actually do need to challenge your balance and do actual balance training to be able to improve that. So we've included that in the Neuro program as well. And that's in addition to what we tested in LIFTMOR.
And when it comes to improving bone and muscle strength, how else does it impact the other areas of healthy aging, be it in terms of metabolic health or even cognitive health?
One way to look at the health of your muscles and bones is like it's the absolute fundamental structure that we need to be healthy so that we can keep everything else healthy. So We know that exercise is really good for the heart and the lungs and the brain, the metabolism. The list is endless. Exercise is good for all of those systems. It's good for many conditions, and it's certainly good for mental health. If you have an injury like a hip fracture that stops you being active, you can't look after all of those other systems. So keeping
Right.
your bones and muscles healthy is really important for being able to look after every other system. So it's the absolute fundamental body structure that we have to maintain.
So what you're saying is that that plays a crucial role, be it in terms of your health span or longevity as well.
Correct. Absolutely does. And it is very, very underestimated and undervalued because, well, you can't see your bones. And so people sort of, what you can't see, you don't need to worry about.
Yeah, God.
Um, and there is a little bit of a concept that doing exercise is either it's hard or it's unpleasant, it makes you sweat, or associated with vanity and wanting to look slim and svelte, when in actual fact none of those things matter when
Right.
we're talking about trying to have a good quality of life for the rest of our life, because just being strong and able to stay on your feet is incredibly important. And that's what muscle training does.
Talking about vanity, have you ever seen anyone with probably good muscular structure but weak bones?
Uh, Look, it's possible because remember I said that most of our bone size and strength is determined by our genes. So yes, it is possible, but it's less likely than somebody with big muscles. They are much more likely to have big bones because also if somebody, even if they haven't been doing any exercise, some people just have genetically bigger bones and muscles, and those two things are actually genetically linked. If you do have big muscles, you probably also have good bones.
You've spoken a lot about osteoporosis. Firstly, what is osteoporosis? And you also mentioned osteoporosis is really a childhood disease. Can you explain that idea? And could you take us through the life cycle of, the remodeling of human bone?
Yes, so osteoporosis is just like the word would suggest. Osteo means bone and porous is obvious. So this is a condition of reduced bone mass and strength that increases your risk of fracture. So there's all sorts of ways that you can get it, but as I say, primarily it's a genetic condition. Just because you will develop less bone than others. So the trajectory of bone growth and loss across life is how I explained earlier. We develop bone up to most of our bone is developed, and we call it peak bone mass by the age of 20. Men develop a little longer than women. It plateaus for a while and then it decreases. And women have this accelerated decrease at menopause. So women gained less peak bone mass to begin with, lost more across life, and so they do have greater risk of osteoporosis at the end of their life than men for that reason.
Right. And for parents and grandparents, what are some of the best things they can do to help kids
Yeah.
build strong bones?
The best thing you can do and answer the rest of your question today,
Yeah.
osteoporosis being a childhood disease, the best thing you can do is optimize your peak bone mass. So get as much bone as you possibly can during childhood, and the recipe is the same as it was for the rest of your life. Lots and lots of bone loading, lots of jumping and running and
Yeah.
multiple activities, tennis and basketball, volleyball, netball, hockey, and things where you're doing a lot of running and moving around a lot. And then, of course, making sure that your diet is very healthy, very well balanced, and particularly make sure you're getting enough calcium and vitamin D so that you can absorb that calcium. So those are the building blocks so that you can actually adapt to the mechanical loading and optimize your peak bone mass.
We talk about osteoporosis, sarcopenia, and arthritis. All these can affect mobility and, of course, independence. How often do you see them occurring together?
All the time. Yeah. So that's why the term osteosarcopenia has been coined, because, it's very, very common to see the two conditions together. So clearly somebody who's not been very active and has not been loading their bones hasn't been using their muscles either. So, you see lots and lots of old people. When you look at their thighs, there's almost no muscle left there at all. No wonder they fall over. They can hardly keep themselves upright.
Right.
So they're certainly not loading their bones with nice, strong muscles. So those things do coexist.
And would you approach exercise in a different manner for someone with osteoporosis versus arthritis?
Yes, because arthritis, which is a condition of pain of the joints, does cause pain. And so you have to be cognizant of that. Anything that's causing pain is probably not really benefiting the tissue. But the good thing about arthritis, what we've learned in recent years, whereas doctors used to say, if you've got arthritis of the knees and hips, then you should not be doing any kind of activity. You should rest them so that you've got no pain. Actually, that's the worst possible advice. You need to be absolutely exercising your joints, particularly knees and hips. And the more you do, the better it is. And a lot of times, the belief is still that you shouldn't be applying any kind of impact to an osteoarthritic knee. And that's not true either. In fact, a little bit of impact is good for arthritis. So there are, of course, stages, grade 1 through grade 4. There will be different recommendations for those, but you just have to be cognizant of the fact that joint pain will not encourage somebody to come back and keep training. So you have to modify an exercise program so that somebody can tolerate it. You may have to put the bone loading on the back burner for a little while until their bones get strong enough to tolerate it, and then you start loading. And every person is different, and so your approach with them should be different.
Do you see any warning signs that arthritis is beginning? What happens first? Is it like muscle? I mean, is it bone loss, or is it arthritis that sets in on a general basis?
I'm going to stay in my lane on this one. Osteoarthritis is not my wheelhouse. It's probably not. There's been a lot of work done in recent years, and I think the jury is out in terms of which the chicken and the egg situation there, but there's probably two schools of thought, and I'm not across the literature enough to weigh in on that one.
Tell us a little bit about the bone clinic. How did the bone clinic bridge research and community care, and how is Oniro being used to scale evidence-based musculoskeletal health?
So the Bone Clinic is an extension of my research program here at Griffith. So this is where we've rolled out the LIFTMOR program, the HIRIT program we tested in LIFTMOR, into a community health clinic. So everybody who comes is a research participant. So we do really comprehensive measures on them at baseline, and then they do Oniro twice a week, but it's a clinic, so they pay for it. So
Right.
we're also testing feasibility and sustainability. And then at the end of 12 months, we test them again, and they stay for as long as they want, because bone is a use it or lose it tissue. So really, you need to be doing Oniro for life. Now, we've been open, as I say, for 10 years now. We have some incredible data. We've got nearly 500,000 exercise sessions showing really great safety if it's supervised by people who know what they're doing and are well trained. And we're growing bone in old people like crazy. People aren't falling or fracturing. This is a real step change in the treatment of osteoporosis. And probably the best thing about it is the feedback that I get from clients who say,
Right.
this has changed my life. I'm
Yeah.
just a different person than I was. And I now feel like I'm able to do all manner of things. I came here for my bones, but I'm staying for all the other stuff. Actually license the Oniro program. So we're not the only people who are offering it. So physios and exercise physiologists around the world now can also offer Oniro.
Talking about testing, is there a gold standard assessment for bone and muscle health that you would love to see become more routine?
Gosh, that is $1 million question. And right now, there's no one thing that is the best. DEXA is what everybody uses. It's bone mineral density testing using dual energy X-ray absorptiometry. It's what your doctor will send you for if you want
Right.
to test and see if you have osteoporosis. It has flaws. It has significant flaws for all manner of reasons. And that said, it probably is still the most consistently reliable and precise measurement instrument we have, as long as people are using it correctly and interpreting it correctly. So DEXA is the measure. You can also look at lean mass and fat mass, which we do. We do whole body testing as well.
Right.
In terms of testing muscle, probably function is the best way, because just doing a pure muscle strength test is not particularly useful. We want to know things like sit to stand tests and
Right.
tandem walk, looking at balance and so on.
Can genetic testing really help predict someone's risk for osteo and sarcopenia?
I mean, I don't see any sense in doing it, because as soon as you know that you have low bone mass, you should be doing something about it anyway. There's no way to really predict whether someone's going to have a fracture or not, because two people with the same BMD, one of them's going to fracture where the other one won't, just basically by virtue of the difference in their risk factors. So it really is very much an individual condition and depends very much on somebody's history.
Right. And, just talking about, we've spoken a lot about exercise. When you look at the LIFTMOR study and even the MEDEX OP trials, they did show that older adults could safely lift heavy weights, even with low bone mass. But how do you think that changed the old way of thinking?
Well, I think it's pretty safe to say that most people have this sense that the older you are, the less you can do. And so we must all um, wrap our old people in cotton wool and do everything for them. And, you often hear about people who, in Australia anyway, who downsize when their children leave the home, and they downsize from their multi-level home so that they don't have to manage stairs anymore. And that's the absolute worst thing they can do for their fitness.
Oh yeah, it's the same here. Like we cannot stay in a building which has two levels. We can't climb
Mm.
stairs. We need somebody to drive us. We need to somebody to walk with us to the. They don't even walk to the stores to get. It's these days it's all delivered homes. So it's like you're absolutely right. I think most of them just live in this world.
It's just crazy. You're just waiting to die. I mean, if you want
Yeah.
to live your life, then you have to actually live your life. And that's right. And the less you do, the less you're going to be able to do. So if you want to be able to travel and carry a suitcase around, then you need to travel and carry a suitcase around.
While of course I think most people are quite familiar with the LIFTMOR study. I just wanted to understand, what is your take on the MEDEX study?
Well, I understand it very well because we also ran that one. This was a study. Once we had run LIFTMOR and LIFTMOR for men, we then understood that this particular heavy lifting and impact was not only effective but safe for people with low bone mass and at risk of fracture. The next logical question was, if somebody is in a situation where they're diagnosed with osteoporosis and the doctor is saying you should take these tablets, and then here's Belinda saying, well, you should do Oniro exercise. Which one do you do? Or if you do them both, is it better? And nobody knew the answer to that. We didn't know. So we decided to do the MEDEX-OP study. It stood for medication and exercise for osteoporosis. And because none of us are doctors, so we aren't able to prescribe medication, we recruited people who were both on and off medication, and we stratified the randomization so there were equal numbers of people in the exercise intervention group and in the high risk group, and not. And so that way we were able to test whether there was an interaction between the exercise and the medicine. Now, the problem is so few people are on medication. It's really hard to recruit enough people in those trials to be able to see if there's an effect. Out of 100, more than 100 people in that study, we only ended up with about 30 people. But if you look
30
at the
people without 30 people without medication. Is that right?
30 people who were on medication.
On
So
medication.
it's only about 20% of people that really could potentially be on meds who go on and stay on meds. It's not a well accepted therapy at all. Of those, what we found, and I mentioned the fact that we only had a few in the study because I'm a scientist, and so small numbers does limit how much you can believe of what you find. But what we found was those who were only on medication gained about the same amount of bone across the 8 months as people who were only doing the high intensity resistance and impact training. So it was about the same effect. And then if you had somebody who was on both, they're on meds and doing high rep At the spine, there wasn't really much of a difference. It was about the same effect, about the same amount of improvement. At the hip, there was slightly more improvement. When you look at the same question at the clinic, at the bone clinic, where we have people just coming to the clinic for treatment, and so we're looking organically at the combination of meds or no meds because people have the choice to do either. And when we analyze the data, there is certainly some indication that those people who are on meds are probably getting more benefit across the course of a year than if they're just doing exercise and not on meds. There's some suggestion that that might be the case, but it's not necessarily saying that if you're on meds, the effect of the exercise will be better. It's really just additive.
Yeah. When we are talking about medication, what sort of meds are we talking about?
So there are sort of two classes of drugs for osteoporosis. One is an anti-resorptive drug. So these
Right.
are suppressing the osteoclast and preventing as much resorption that happens during the remodeling process. So that would be bisphosphonates or the rank ligand inhibitors, so like denosumab or Prolia.
Right.
A bisphosphonate would be something like Fosamax or Aclasta or can't remember the other name, Actonel. And then there's the anabolic drugs, and these are the ones that actually act on the osteoblasts and help to create more bone. Now, those are the ones. Originally, probably the first anabolic drug was PTH, so based on a parathyroid hormone, and that was teriparatide. Now, a different company is making it, and I forget the name of that one. There has been a new drug that has come out recently, which acts on both cells. It's romosozumab, or marketed in Australia as Evenity.
That's right.
Uh, that one is actually considered to be the most effective of all. There are some limitations as to who can be on it because
Right.
is some suspicion of cardiovascular risk, and you should only be on it for about 18 months, is my understanding.
Right.
So the thing is, if you go on a drug like Prolia, that's the one that you have a shot in the arm every 6 months,
Right.
and you stop having your 6 monthly shot. 6 months after you should have had your follow up shot, you will have lost a huge amount, probably all the bone that you gained. And for some people, that actually increases the risk of fracture. So there are definitely things that you need to talk about with your doctor before you go on and before you come off drugs.
What have you seen? Is anabolic meds work better than anti-resorptive, or what's your take on it?
Well, because we don't really monitor drug effects in the clinic, I don't collect data on that. I'm just reading the literature and listening to conference presentations like anybody else. And from what I can tell, the newer drugs, such as romosozumab, there's also another one, abaloparatide, which is in the sort of PTH train. Those are probably the effective in the short term.
Right.
They haven't been around for long enough for people to know how effective they are in the long term, and certainly for very long term side effects. And this is the problem with bone drugs is over the years, sort of the last 30 odd years, every time they come up with a nice drug that does good things for improving bone mass and preventing fracture, after a while they discover side effects that make them unappealing. And in the case of the anti-resorptive drugs, that tends to be things like osteonecrosis of the jaw and atypical femoral fractures. And so that's why they're constantly looking for a different class of drugs to try and get around that effect. But if it's an
Right.
anti-resorptive, there's always going to be that risk because resorption is such an important part of bone metabolism.
But have you seen using both exercise and meds, like in the study? But have you seen, significant drop in the side effects of people who were exercising?
No, no
No.
relation. No, doesn't
No.
make any difference.
And how do men differ from women when it comes to musculoskeletal, the entire way it works, and even in terms of nutrition and supplements and medication synergy, etc.? Do you see any difference between men and women?
Well, if you talk about bone tissue per se, there is no difference. Bone, you've got the same cells. Mechanotransduction is the same. You react to loading on a tissue level. But because women have much higher circulating levels of estrogen, the mechanism that we have of protecting bone is very strong until menopause. Again, not being an endocrinologist, I can't go down the track of giving the ins and outs of male endocrinology. But clearly the difference in terms of the trajectory of bone growth and loss across life is it's largely the same as for women, although they gain more bone before peak bone mass. They don't have the rapid loss of menopause because they don't suffer that insult of the sudden withdrawal of estrogen, but they
Right.
do still have reductions in other forms of hormones. Testosterone is important, and estrogen does have an influence as well across life. So
Right.
I suppose it's just a more dramatic sort of effect in women because of the dramatic change in estrogen across life. But basically, male bone will respond to the same stimuli as female bone, whether that's chemical or mechanical.
So are you saying that probably like even men do lose testosterone after the ages of 45? So does TRT work for men in terms of bone health? What's been your experience?
Yeah, I have no experience with that.
What are your thoughts on supplementation, especially like vitamin D?
Yeah, wow, that's a rabbit hole. So, um, there's so many ways to answer that question. If I was to answer it in from only one standpoint, I would say my mantra is food first, always. Food is the absolute best source of nutrition, and if you have a balanced diet, you should be fine. But the trick is a balanced diet. And there are some people who have allergies and intolerances, such as lactose intolerance, which does limit their ability to tolerate dairy. And dairy is the primary source of calcium. It's very calcium dense and it's very bioavailable, meaning we absorb it very well. So if you're not a dairy person, then you have to look for other sources and you have to be very careful about getting enough. If you can't get enough through your diet, then supplementation is probably important. And then you need to speak to your dietitian about what sort of supplement you should take, because certainly calcium carbonate is less absorbable than calcium citrate. There's all sorts of subtleties there. And of course, if you're not getting enough vitamin D, you can take all the calcium you want, but you won't absorb it. So that's
Absorb it.
the important function of vitamin D. Now, darker skinned people don't tolerate or don't convert as much vitamin D in their skin. People who cover up for cultural reasons are not getting sun on their skin. So those people are probably more likely to need supplementation. In Australia, we have a population who is the majority of whom are white. And so we have one of the highest rates of skin cancer in the world because we're in such a very strong sun environment and very fair skin. So we have a very strong covering up mentality. So protecting ourselves from the sun to the extent that we use sun cream, hats, long sleeve shirts in summer. And it was discovered decades ago that we actually have an insufficiency problem with vitamin D because of this real concern about skin cancer. So there's an important need to get the Goldilocks amount of sun, expose your skin to sun when it is actually safe. So before the hottest times of the day, but make sure you get some sun because sun is by far the best way to get your vitamin D. Food sources, pretty difficult. Red meat, salmon, butter, mushrooms. That's about it. So, yeah, the sun is the best source. And sunlight exposure of your skin is actually good for all sorts of things. That's what I recommend. In terms of all the other micronutrients that people talk about, honestly, if you're eating a balanced diet, you're probably getting enough of those. And my own personal opinion towards supplementation of that is that you are just creating very expensive urine.
Right. In fact, South Asians, especially Indians, a majority of Indians lack vitamin D, adequate amounts of vitamin D. Despite the fact that we do have a lot of sunlight, but it's pretty surprising the number of people who struggle with getting their optimum levels of vitamin D. Again, that's a question of being dark skinned, whether we are spending enough time in sunlight or not. Now, you did mention that, most supplementation doesn't really help, but we often hear vitamin D and K2 is great for bone health. But from your perspective, what would you weigh in more, exercise versus taking vitamin D and K2?
Well, 100% the exercise is more important if we had to balance them on a scale, but you can't really have one without the other because you need the building blocks, which is calcium, and you need vitamin D to absorb the calcium so that you can create more bone. So they are absolutely complementary. but you won't just turn around osteoporosis just with diet, whereas exercise will allow you to turn around osteoporosis. So it's a much more powerful therapy. It's just that they're both very important. You need both. Normally, when you're thinking about diet, you're aiming for sufficient amounts of the nutrition that you need. When you're thinking about exercise, you're actually looking to overload. So you need, to actually stress the bones. It's not the case for diet. You don't want to have more than you need. In some cases, it's bad to have more than you need. And in fact, in some of the vitamin D studies, they've shown where these hyperdoses that they have been giving people are actually quite toxic. They increase the risk. They increase the risk of falls, which increases the risk of fracture. So more is definitely not better. When it comes to calcium, you also don't want to have more than 2,500 milligrams a day, and you should be having it in small chunks. There's really no need to have more than 1,300 milligrams a day. Um, and if it comes to vitamin D, the recommendation is about 800 international units a day. So
And again, that would vary between Caucasians and South Asians because we are smaller boned, in terms of both structurally as well as volume wise. So I think probably our quantities would be smaller in dosing.
yeah, I have momentarily forgotten the name of the vitamin D expert who is one of your countrymen. I listened to an excellent webinar he presented just recently. And I think he's in your medical community. I believe he's an endocrinologist, and he gave a really great discussion about the kinds of vitamin D levels that are required. And he's basically parroting him because I do trust and respect his opinions. I think for people where there's a deficiency, there is absolutely an argument for supplementing. You might need to supplement a little bit more for people who are deficient to get them up to speed. But as a maintenance dose, there's nothing to be gained by taking more than 800 milligrams a day.
There seem to be a lot of people who believe in collagen, right? While yes, collagen does make up a major part of the organic matrix of the bone for flexibility and strength. What are your thoughts, and what does it? Is there strong evidence about collagen supplementation? Does it really help bone health?
As far as I'm concerned, there's no quality evidence of that. The trouble is, it makes intuitive sense to eat more of what bones are made of.
Right,
And that would be right if what you eat can be transferred directly into the bone. And
right.
that can work with calcium, but with a peptide that tends to be broken down in the stomach, if you're swallowing a bunch of collagen, I'm not sure how much of that collagen is going to make it to your bones. It probably will. They'll be broken down into amino acids. They can rebuild and so on. But again, the idea of taking a collagen tablet to help build bone, that's just not how physiology works.
Got it. Along the same lines, what are your thoughts on protein supplementation?
It's certainly the case that if people are deficient in protein, then they are not going to respond as well to a training stimulus. There's no doubt there. And there's plenty of evidence that the older populations begin to eat less protein throughout life. And so there is definitely a reason to consciously be aware of the protein you're eating and make sure that you are eating enough that the recommended amount. To talk about supplementation and in any particular amount in relation to training, I can't tell you if there is a certain amount you should eat to benefit bone because those data just don't exist. So again, it's the same story. You just eat a balanced diet, get all the protein that you need for it's something like 1 gram per kilogram per day of protein. Maybe bump that up a little bit. It's not going to hurt you if you eat a little bit more. If you are training heavily, see if it works for you. But right now, there's no evidence to show exactly that is going to benefit your bone outcomes.
In your experience, what population groups are still very underserved in bone health research? Is enough research happening on certain populations or not?
Yeah, I suppose when it comes to the exercise area, my area, much of the work has been done in Australia. That's me.
Right.
And some other people in Australia are also doing exercise research or have done. And there's a little bit sort of smattered around the world that others are doing. And so when I'm recruiting for my studies, I'm recruiting from our population. Now it is a multicultural population, but the kinds of people who tend to volunteer for research studies tend to be white women.
Hmm.
And, if we're doing a men's study, tend to be white men. That's just the nature of the people who tend to volunteer for studies. So it's possible that in our more multicultural community that the research that findings that we have are not 100% applicable to everybody, but there's no real reason to think that that is the case because bone is bone and it's largely the same irrespective of race. So also we have our living human experiment at the bone clinic where it's not a randomized controlled trial. Put out a call for to recruit into the study. It's a health service, so anybody can come, and we do have a much more multicultural clientele at the clinic, and the results are the same. The effect is the same.
Got
In
it.
terms of other research questions that we don't know, I would love to know if um, Onero is able to prevent the loss that happens when people stop taking Prolia. We have some preliminary data to show that it does, but we need a much bigger sample to be able to test that. I would love to know if Onero can either prevent loss or regain lost bone for women who have had aromatase inhibitor therapy for cancer. And we have many people coming to the clinic because they had breast cancer. And so their bones are in a bit of a mess. So I'd love to know whether Onero can rescue those people. My strong opinion, and from the small amount of data we have, is that he can. But I would love to be able to show that. Same question with steroids, glucocorticosteroids, which are terrible for bone. Can we, if somebody is going on a high dose course of that, can we prevent some of the bone loss they're going to experience by at the same time putting them on Onero? Those are the kinds of questions that I think are really clinically relevant.
Yep. Talking about cancer patients, what's been your experience with Onero in terms of does it help them recoup and recover their bone health? And even in terms of did it help them prevent recurrence of cancer? Did you see any of that?
Well, because we don't track recurrence, so I don't have specific data, I can't answer the second question, but certainly we have a number of cases of people who, having had cancer treatment, have come to the clinic, done Onero and regrown bone. Absolutely. And it's not just that they're regrowing bone, it's the fact that they are regrowing muscle, they're taking control. There was a period of their life where they felt like they had no control. This disease had them in its clutches, and they were at the mercy of the doctors giving them these drugs, which made them feel terrible and, were were actually quite harmful to some systems while they were curing cancer. So being able to come and do something proactive, healthy, that really builds up their muscles and bones again is a very empowering and psychologically positive effect. So we definitely see that. And as I say, it's the reason why I'd like to look at that more closely, because we'd like to collect actual data with large subject numbers so we can tell the oncology community that this is something that is beneficial. I am aware of the fact that when people are on treatment for cancer, that they do get very tired. And so the idea of going and doing intense exercise is not appealing. So the idea of it being something to prevent the loss caused by the drugs, it may not ever be practical because people might just not want to do it. And that's very understandable. But we can help them after the fact when they start to recover. And I think that's a very feasible approach.
Coming to people recovering and recuperating from any sort of serious disease, be it in terms of post surgery recovery or even cancer health, most people think that this individual is very fragile, so we got to protect and ensure that the individual doesn't get into any injuries. And so most people tend to simply stay put at home. And in those situations, what would you suggest people do?
During the recovery phase from surgery
Yeah,
or for a
especially during
condition?
surgery, because I think that's where people lose a lot of bone.
Well, I mean, it's the same recommendation. it's very important that you get on your feet as soon as possible. Lying down and sitting down, it's it's the worst. So get on your feet as soon as possible. And I understand orthopedic surgeons, when they do their rounds, the day after surgery, have you been out of bed yet? And even with joint replacements and back surgery, can you get up on your feet? Because it's so important for their recovery. So do that. Get up on your feet, as you will have got some exercise recommendations that you can do at home from either the surgeon or the physiotherapist. Do those. Absolutely do those. You might not feel like it. You might be in a bit of pain, but take your pain medication and then do it when you're not in pain. And you start very gradually, and then you just sort of work up. If you then have the opportunity to go to physical therapy and do rehab, you absolutely should go. I cannot overstate the importance of exercise therapy in those situations.
What simple things can people do at home to improve their balance and coordination?
Well, this is one thing that I can say, that you can go online and look up balance activities and just Google it. You can find hundreds of balance training exercises that you can do safely. But if they must challenge your balance. If they don't challenge your balance, you're not actually training your balance. If you can stand on your foot for 30 seconds without wobbling, that is not balance training. You
Right.
need to do something else while you're standing on one leg, like maybe tossing a ball in the air and catching it while you're standing on one leg. Doing exercises that perturb your balance. So sort of rocking forward and then be training your muscles to react quickly and catch you. It will
Right.
help you catch yourself if you go to fall in the future. I do recommend that if you are doing this by yourself, that you are doing it standing near something that is heavy and firm and unlikely to tip over, that you can grab if you do go to fall, because that's the problem, right? When you're training to prevent falls, that you might overbalance and you don't want to cause the fall. So always have a railing, a handle, a couch, not a light little kitchen chair that's likely to just go over with you. A kitchen bench, maybe something firm. But yeah, you'll find hundreds of balance activities online, and I really recommend you do them. The latest guidelines said you need about 2 hours of balance training a week to really change your risk of falling. Now, that's a lot. You can include other exercise in that 2 hours.
One of the key things for balance is also the eccentric motion, right? That also becomes important.
Yeah, I think training the muscles in every form of contraction, whether it's eccentric or concentric, is important, because our movements are comprised of a combination of muscle contraction types.
Got it. And why does posture matter so much to prevent falls, and how can we keep it from slipping as we age?
Once again, I don't think you're going to be surprised to hear me say exercise. Standing up straight allows you to be able to look straight ahead and have vision over your shoulders. So if you're very stooped over because you have a kyphotic curvature, really you're looking down and your ability to look around is much curtailed. If you are walking and you're in that sort of stooped position, you can't see the neighbor's dog come running out onto the pavement. And so it's going to give you a fright and you're much more likely to fall over. You can't see the person backing out of their driveway in front of you or the kids riding their bikes. So having good posture keeps your face up and your vision forward. And that's really, really important for preventing falls.
So what you're saying is the more we stoop, our peripheral vision gets reduced.
Plus, if you do become stooped, then you instead of having your center of mass over your base of support, which is how we maintain our balance, you then suddenly have this unusual posture where you are much more unsteady just by virtue of the fact that your center of mass is different from what it used to be. And that's why oftentimes somebody will need a walking stick to take some of the weight of their forward shifted center of mass. So yeah, very much, very important to keep an upright posture.
We seem to be seeing a lot of people undergoing knee replacements, hip replacement surgeries. Why is that? Is this something new, or have you been seeing this for a while? What's causing this? Is it a trend?
Well, I would say it's a combination of the fact that people are living longer.
Hmm.
So they are probably in better condition when they're older. So doctors think it's worthwhile replacing a joint so that they can remain mobile and active throughout the rest of their life. The procedures are more available, more affordable, more reimbursable by the government, probably. And it's possible that the approach to joint replacement now is less of a situation where you're trying to fix the joint just so that you can remove pain, and more you're replacing a joint so the person can remain active for the rest of their life, because it's that activity that's going to maintain the rest of their bodily health. So, yeah, it's a health span kind of a situation.
Have you seen people extending, the bone health with exercise, of course, and in all likelihood it is so, but have you seen any sort of remarkable delay? Let's say somebody has got severe knee pain or hip issues. Have you been able to kind of help them either delay their surgery or probably even not go in for surgery? Have you seen any of that?
Yeah, absolutely. But again, there are levels. So there's people who have very mild forms of knee osteoarthritis, and we almost certainly are able to help them by making the muscle stronger around the joints. You absolutely can reduce symptoms of pain, and it's actually good for the cartilage in the joint. So it's therapy. So in the sort of grade 1, grade 2 range. If somebody is more advanced and there's very little cartilage left and a lot of pain during movement, we can almost certainly improve their function and possibly even their range of motion. But it's highly unlikely that we will be able, you can't fix OA with exercise when it is very, very advanced. So that's sort of a knee replacement kind of situation. But we can certainly make them more comfortable and we can improve their function. It's probably a case if someone has a grade 4 knee OA, there's somebody who is waiting for a knee replacement.
Right.
Having our training, what they call prehabilitation, making them stronger before they have surgery, is absolutely going to improve their outcomes, because they'll be stronger going in and they'll have more to work with when they come out of surgery and start their rehab.
Dr. Beck, we are nearing the end of our time. But before we wrap up, here on Brighter 100, we always end with a tradition of a few light-hearted, quick-fire questions, just to get to know the person behind the expertise. Are you ready?
Sure.
Great. So, if you could put one message about bone health on a giant billboard for the whole world to see, what would it say?
Do a Nero. Honestly, there's no other way to put it.
Right.
I would obviously have to put what a Nero is underneath the giant words, but that is the answer. That's the question, and that's the answer.
For people who don't know Oniro or anything about Oniro, why don't you give us a quick, short note about Oniro? What does it actually do? And what does it entail?
So Oniro is a high-intensity lifting and impact training program that you need to do a couple of times a week. It's quite brief, though. The sessions are quite brief. And you need to do it for life, because it will build bone, it will build strength, whole body strength. It will improve your function in multitude of ways. It will reduce your risk of falling by improving your balance and your mobility. And it gives you just a massive boost in your quality of life because of all the other things that it allows you to do. And along the way, you'll probably meet people in class. So it is great for your social life and your mental health. So yeah, it's really an all-in-one kind of program.
I'm just going to go back to those questions. What's the one habit you've kept for years that you think has made the biggest difference to your health?
Well, strange as it may seem, the number one thing, and one of the things I look forward to most every day, is reading fiction just a little bit every night before I go to bed. So reading non-science, just a beautiful story every night before I go to bed. It switches off my brain and it gives me real pleasure.
If you could have dinner with any scientist, athlete, or any historical figure, or even a physician, who would it be and what would you want to ask them?
Oh, wow. So many. So many. Yeah, I know. I'll answer this question and then I'll go away and kick myself that there was somebody way more interesting that I would like to talk to. But quite honestly, one of the people who I would most love to just sit and have a chat with is David Attenborough, because he and I share a love for the natural world, and the experiences that he would have had, I would find utterly fascinating.
Talking about natural world, have you tried to study from an animal perspective in terms of the bone health? Have you done any of those studies comparing that to human bone health?
Nothing comparing animal health to human, but I did start my research career doing animal research and studied a turkey ulnar model. So I have done a little bit of animal research, and because I do love animals so much, I just knew that I couldn't spend the rest of my career killing animals, even if it was in the name of science and the human health. So I leave that to others. I'm not anti it. It's just that I don't have the stomach for it. I don't want to kill animals.
Well, Dr. Beck, this has been such a powerful conversation, not just about bones and muscles, but about what it really takes to live strong, healthy, and confident, at any age. So thank you very much for your time, and thank you for sharing your wisdom and passion with us. Thank you.
My pleasure. Lovely to be here.
And to our listeners, remember, it's never too early and it's never too late to start building the strength that'll carry you through your life. Until next time, stay curious, stay strong, and keep moving forward.